Hello friends, welcome to Mad Medicine. This time the topic is gout, so let's have a view by the lecture. These are handwritten notes which are inclusive of all the stuff which is in Harrison's standard books, even the previous year's questions and important stuff. These are the images. Okay. Yes. So let's start with gout, and as you know, this time also we have Harrison's with us. So already 90% of the stuff of Harrison's is covered directly in the notes, and for rest of the small things left out, we have these two photos. Yeah, because it's a small topic. So let's start with gouty arthritis. Okay. So in gouty arthritis, you know what happens? It is the main backbone of gouty arthritis is hyperuricemia. Whenever there is increased uric acid levels in your body, that will predispose you to develop gouty arthritis. So the main incriminating factor is uric acid, and uric acid is end product of purine metabolism. Don't get confused ever. In protein metabolism, for protein metabolism, for protein metabolism, in case of protein metabolism, the end product is always urea and ammonia, all these nitrogenous waste products. But if I'm talking about purine metabolism, the end product is uric acid. So it's very confusing. Protein, urea, purine, uric acid. Because you are seeing this, I always use this figure of speech of alliteration. The same alphabet or the same alphabetical sound is coming again. So uri, that means uric acid. That means uric acid. So purine, that is uric acid, and protein, that is urea. Okay, this was done simple. Now let's get back. So final breakdown of purine metabolism. Now primary gout is occurring in the body. The causes for primary gout are two. Number one, it is increased production of uric acid. Number two, decreased excretion. So increased production and decreased excretion. This is clear, very simple. Whereas secondary gout can occur, then you will ask me, then why will secondary gout ever occur? Secondary gout can occur because of certain other features. Secondary gout can occur. Oh my god, just wait. Actually, if I increase the thickness, then we will be able to write less if we make big alphabets. Let's try with this now. So in secondary gout, what will happen? It can be because of any reasons, such as there is a kidney disorder, the kidney is not able to clear out uric acid from the body, or it is drug induced. There are certain drugs which increase the uric acid, that cause hyperuricemia. And similarly, it can be because of other disorders such as malignancy. In malignancy, there is increased cell turnover, or it is because of some genetic conditions, such as certain genetic conditions can also be there. So these are the various features of secondary gout. Whereas primary gout means primarily there will be increased production of uric acid in the body or decreased production of uric acid by the kidney. And out of these two features also, if I ask you point number 1 and point number 2, which is more important? Is it point 1 or is it point 2 which is more important? It is point number 2 which is more important. So if I ask you, out of these features, it is decreased excretion of uric acid which is involved in most of the cases. Okay. Now you also need to know what is the normal levels of uric acid. It is 4 to 7 mg/%, but hyperuricemia occurs whenever it is more than 7. So the person has uric acid 7.1, 7.2, he has come into the category of hyperuricemia. So whenever uric increases in the body, initially it is in your blood. Initially this uric acid will remain in your blood. It is running in your blood. There are blood cells, and there is also this uric acid which is running there in your blood. Okay, and it is in a soluble state. So for this, you can always remember this example, that for example, you have a tumbler, you have a glass, and in this glass you want to add sugar. So you keep adding the crystals of sugar in this glass. These crystals of sugar, they will always form a homogeneous true solution. They will never stand out. They will form a true solution. They will completely remain soluble and dissolve in that water. But now what happens after this, beyond this level, you keep on adding 1 spoon, 2 spoons, 3 spoons, you keep on adding. Now say after the 5th spoon, the 6th spoon that you add, now the solubility limit of water is exceeded, and now that extra sugar will start to precipitate and will start standing out and not anymore mix and match and be soluble in this solution. So the same thing happens in your blood. Whenever we have the blood, initially the uric acid, it will be present in the blood, and it will be there in a solubilized form in the blood. It will be in a solubilized form. But after that, what happens when the solubility level increases, and that first stage is called supersaturation. That first stage is called supersaturation of blood. The blood is supersaturated with uric acid, and after supersaturation now comes the second dreaded step, and this dreaded step is that After supersaturation, there starts nucleation. That means now this uric acid, it is forming crystals of uric acid. It is no more only uric acid. Now it is uric acid, means urate. Any acid, it has a negative charge on any acid, it has a negative charge, right? Uric acid. So urate crystals are there. And now that, sorry, any acid has a positive charge. It has one proton, so it is in a protonated form. For example, just wait, what am I saying? 1 second. If the acid has not lost its hydrogen, for example, we have acetic acid, CH3COH, there is no charge. But once this acid has lost its proton, H positive ion has gone, so yes, now this becomes acetate. So similarly, when it is uric acid, there is no net charge, but once uric acid loses that proton, now it becomes urate, and this urate has a negative charge. Whereas if I ask you about sodium, Na, it has a positive charge. So this positive and negative, these moieties together, they will form monosodium urate crystals, and this is the main feature. These monosodium urate crystals, these will start to accumulate in the joint cavity, in the synovial fluid, and they will cause all the features of inflammation. They will trigger the inflammatory systems in the body, the cascades through the complement pathway, neutrophils, and from another pathway directly phagocytosis by the macrophages, and that we will discuss when we will come to the pathogenesis with the help of a simple good image. Okay, so right now this level is fine. 2 stages you understood. One was supersaturation, second was nucleation. After nucleation, there is crystallization, means frank formation of crystals everywhere, and they have a predilection to deposit at what all sides? They have a predilection to deposit in your joint cavities, means in the potential space, that is the synovial cavity. Number 2, they can deposit even in the periarticular soft tissues, and number 3, they also deposit in the kidney, in the renal tubules. They deposit to form renal stones called nephrolithiasis. So these are the various features where all they can deposit. Okay, yes, so this all was clear now. Okay, and then there is one finding that various research studies have been performed, and they have given us this, means sort of data. It is not always important, but a close figure has said that if the serum uric acid is more than 9, the chances to develop gout is 22%. That means if there are 10 people, who have uric acid levels more than 9, means it is way beyond normal. Normal is 4 to 7. They have 9 or more than 9. So 2.2 means around 2 or 3 people out of them will develop gout in the future. That means after a period of 10 years to 30 years. That latent period is very high. In a period of 10 to 30 years in the future, they will develop the manifestations of gout. Okay, so this we have done. Now obviously there is a direct proportionality between the serum uric acid levels and the chances of developing gout. I even gave you the figure that if the serum uric acid level is 9 or more than 9, the chances of developing gout are 22%. Okay, now initial episodes of gout means, first what happens in the plasma, there is hyperuricemia, and this hyperuricemia, the supersaturation of plasma occurs. From that stage of supersaturation to the formation of crystals, and these crystals inducing an inflammatory response in the body and manifesting in the form of an acute episode of gouty arthritis. This period can take anywhere from 10 to 30 years. 10 to 30 years of asymptomatically the patient will be there. Only in his blood, the blood profile only will show hyperuricemia, uric acid more than 7, and he will not have any pain, he will not have any symptoms, no inflammatory signs will be there for a period of 10 to 30 years. So this is again a long latent period, because in this period what is happening, there is only plasma supersaturation, and the nucleation and crystallization has not occurred. Whenever the uric acid is in the plasma, it is in a soluble state. I told you, when it exceeds that limit, like that 6th spoon of sugar, similarly when it exceeds the limit, the plasma cannot hold it. The solubility limit of uric acid in plasma is exceeded. After that it starts to stand out, it starts to crystallize, and it accepts one sodium to form MSU crystals. In these crystals, I told you, they have the predilection for those 3 sites. One is the joint, number 2 is periarticular soft tissues, tendons, etc., and number 3 is the kidney tubules. Okay, now there is no evidence that damage occurs to any organ due to, in these 10 to 30 years usually there is no damage to your body, because urate crystals, if even they are present in low amounts. It is mainly high supersaturation in the plasma. Uric crystals have started to form slowly, and they are not in such an amount to accumulate anywhere to form a tophaceous deposit or to start the inflammatory processes in the body. Okay, that is a latent stage. Now the most common joint involved is, as we all know, it is characteristically the first metatarsophalangeal joint. So if we have this leg, we have this first, these are the metatarsals, and these are the phalanx. So this joint, the first metatarsophalangeal joint of the big toe, is first to be involved. Now you should ask me as a bright student the reason for this, that why only this joint will be involved. So I've done extensive study on this topic of gout, and I didn't find it in any standard books, but more studies with the help of net and various sites like PubMed and all. They told me that why the first metatarso is this joint is involved. There are two reasons. Number one, this joint is a terminal joint, and here the blood supply is less, so there is decreased perfusion. That means there will not be a good blood flow that will help to keep on clearing the uric acid from this area, because if we have any organ which is well perfused, there are decreased chances of any debris or any deposit accumulating over there, because continuously the fresh blood keeps coming, and it keeps taking with it all these inflammatory mediators. Means there is a complete washout, a clearance of all the inflammatory mediators, uric acid, and it won't allow it to deposit over there in such great amounts. So number one is decreased perfusion, and number two is that since this is a terminal joint, and that surface area to volume ratio is such that there is more heat radiation from this peripheral part of the body. So when there is heat radiation, there is relatively cold temperature, and when we will study about uric acid crystallization, there are 3-4 factors, physical factors, that increase the crystallization. One of them is pH, one of them is temperature. So always remember, it is cold temperature and acidic pH, means low pH, and cold temperature means temperature is also on the lower side, means numerically on the lower side, less than 37 degree, and pH also less than 7, any acidic pH. These are the two factors that cause more and more accumulation and crystallization of uric acid. That means if the temperature is high, the uric acid will remain in a soluble state, it will not form urate crystals. Similarly, if the pH is neutral or little bit towards the basic, the urate will not crystallize into crystals and not accumulate in the joints. But if there is colder temperature and low pH, these are the triggering factors for early and quick crystallization. Therefore, the first joint to be involved is your metatarsophalangeal joint in most of the cases. After that, obviously, as the disease progresses, see, the disease can be in two forms. It can be an acute episode of gout exacerbation, acute gouty arthritis, and number two, there is a long-term chronic condition which is happening. Okay. So later on in the chronic condition, different joints such as knee joint, elbow joint, etc. may be involved, but initially it is the first MT joint which is involved, MTP joint. Okay, so you can ask me then, what is the role of uric acid clinically? Because we are saying that uric acid, it has a direct proportionality. If it is more than 9 uric acid for a long time, 20% of these cases will develop gout. But another very big discrepancy is that it is not always directly involved with the gouty arthritis episode, that acute episode, because many a times it has seen and recorded that there were conditions the patient presented with a lot of acute pain and all the symptoms of gout, and when the serum uric acid levels were done, they were in the normal range of 4 to 7. So that was actually shocking, that the person is having gouty arthritis acute episode and the serum uric acid levels are just in the normal range. That occurs because you don't have to look at the final story, you have to look at the journey, how it's happened. They have already passed that phase of supersaturation, and now these uric acid crystals, they may have moved from the plasma into the joints. They're trapped in the joints. In the joints, they are into the macrophages, they are within the macrophages, they are intracellularly present in the macrophages, because that is how the story starts. The story of inflammation and acute episodes of gout starts when these increased uric acid crystals, they're identified by the macrophages and the neutrophils as foreign material. They start the phagocytosis, they start to break, they start to phagocytize and engulf these uric acid crystals. In doing so, a lot of inflammatory mediators are released, and there is lysis of these macrophages and neutrophils and release of so many enzymes, lysozymes, proteolytic enzymes, and there is a lot of injury to the tissue, damage and joint injury. So that means during an acute episode, most of the uric acid, it is accumulated in your joints and it is causing the manifestations in that joints. So the serum uric acid levels during an acute episode may be elevated and may even be absolutely in the normal range. So therefore it is a little delusional. This is the reason that uric acid does not have much value in diagnosis of gout, but the importance is the monitoring of gout. Means once the person is diagnosed, we have done other tests, x-rays and other investigations, and now we are confirmed that yes, the person is having gouty arthritis. Now later on we start the patient on our therapy, pharmacotherapy, the drugs the person is taking. We have asked him to restrict the intake of alcohol, meat, etc. After that, we can do the monitoring that how well the disease is in control. So for that, you can then measure the serum uric acid levels. Otherwise, it is not a very good diagnostic test, and many times during acute episodes, the serum uric acid is normal. Another important word I like to add here, it's not given in any place strictly, but this I remember when we had studied gout in case of second prof in pharmacology. When we studied pharmacology, that point I remember till date, and that point you all need to remember forever is fluctuations. Fluctuations means the acute fluctuations in case of uric acid levels. These are the features that cause acute episode of gout. Means if chronically the patient is having hyperuricemia, means for 10 years he is having a uric acid levels of 9 or 10, he might not be at a risk of developing an acute episode. But that person who has a lot of fluctuations in uric acid in his blood, sometimes he is having 9, sometimes it gets shooted further to 11, then again it comes back to 7, then again for a long time remains high, then again becomes 6. So if the person is having these fluctuations in the uric acid levels, it is these fluctuations from high to suddenly low levels that predispose to an acute attack. And this is the reason many patients complain that they will come to you, doctor, and they will say, hey doc, you have started me with the pharmacotherapy and saying that now my gout will be in control. I started taking the drugs, and after 1 week of taking the drugs, I got an unbearable acute attack of gout once again. So what have you done? Because again, that drugs we have given, these are uric acid drugs. That means they will decrease the uric acid levels, and if they are strong drugs, efficacious drugs, they will very quickly decrease the uric acid levels in the blood, and because of that they may trigger an acute episode of gout. This is the reason we will study the management of gout. We never start with these drugs such as colchicine and uric drugs and allopurinol. We first, in the acute episode for 7 to 10 days, we always manage the patient with drugs such as NSAIDs and steroids, so that once the patient is out of that phase of acute attack, and then we start with lower doses of allopurinol, and we can even titrate it slowly, gradually increase the dose. We never start with high doses, and number 2, we never started with allopurinol in the acute state. So these are the two things to be kept in mind. In acute episode of gout, also always give NSAIDs and anti-inflammatory drugs such as steroids. They will help the symptomatic relief. They will also decrease inflammation, because everything that is happening is inflammation which is induced by these crystals, and so they will also check what is happening, the root cause of the disease, that is inflammation. And after that, for 7 to 10 days, once you have given the patient is in a stabilized form, now slowly start with these drugs, allopurinol, probenecid, etc., and their dose also have to be done monitoring. Initially it's better to start with a lower dose and then see if the patient's uric acid, then means do that continuous monitoring. And now comes the validity and the use of that uric acid, serum uric acid. Keep measuring the uric acid. You started with a low dose allopurinol, and you saw uric acid are still elevated in the blood. They're 10, they're 9, they're not coming down. So now increase the dose and then again do the monitoring, and that is how you have to do. Tighter, a little hit and trial method you have to do, and a little more individualized therapy has to be given, because we are very careful that if we suddenly give these uric drugs, the patient's uric acid will suddenly fluctuate in the plasma, and they will again give that patient an acute episode of gout. So these were the little controversial, paradoxical things that we have already discussed. Now all the simple stuff is required. So let's increase the speed, because sometimes you comment that your speed is high. I can't do that, because already you see the video is already, I think, 10 minutes video we've already done, but I have to explain. This was the basics. I explained you in a very slow rate. I repeated everything 3, 4, 5 times, but now we have to cover a lot of left out theory. How will you manage, what are the investigations, what are the risk factors, and those all things are simple theoretical. No brainstorming, rocket science is not there. So there my speed will be higher. But what you can do, if it is fast, you're not able to catch up at all, you just go to the settings, and the playback speed you can fix it at 0.75. it will be fine with you. You can use it in an individualized way. But now I'm telling you that my space will be faster, because the rest of the lecture, it is all simple stuff, theory, nothing to understand or nothing very complicated. Okay, so you can adjust the speed according to your needs. So the role of measurement of serum uric acid in the diagnosis, hyperuricemia is the cardinal feature. We discussed it is cardinal features because initially for those 10-30 years the patient's uric acid was high, and after that acute episodes occur. So hyperuricemia is everything. It is the backbone. Hyperuricemia, this hyperuricemia causes when the solubility limit is reached, urate crystals are formed, MSU crystals are formed, and then these trigger the inflammation in the joints and the periarticular tissue and cause all these acute episodes and symptoms. Most of the patients have elevated uric acid levels, but the uric acid levels may be normal on occasions of acute episodes. I told you this paradoxical thing. So we are done with this page. Let's get to the next. Okay. The greatest benefit of uric acid levels is again monitoring. The word to be remembered here is monitoring. Uric acid levels, they will help in the monitoring the effect of pharmacotherapy, how well the disease is in control, rather than making a diagnosis. Hyperuricemia patient presents in 5% individuals, but vast majority are asymptomatic. With that is the same thing again, the same points are being repeated, that the patient is having hyperuricemia, but he will remain asymptomatic for those 10 years, 20 years or 30 years. After that, when supersaturation, nucleation, crystallization, all this has occurred, only then there will be crystal induced inflammation and an acute episode with which the patient will present. So most of the time the patient will be asymptomatic. Now coming to the risk factors for gout. The risk factors for gout are non-modifiable and modifiable. In case of non-modifiable, we have males and advanced age, means it is a disease of middle age to elderly males. And modifiable, now all this you can keep in check. You can decrease if you want, right? You can decrease your meat and seafood intake. Similarly, alcohol, sodas, hypertension, this is very important. Certain drugs such as loop diuretics and thiazides, they also cause hyperuricemia as a side effect. Then obesity, postmenopausal syndrome, MI, stroke, trauma, surgery. All these are simple points. You have to repeat them 2-3 times and you will remember them. So now we are coming to the drugs. Yeah, so we are discussing a certain drug. So this is a very important high yield point for all the exams. They will ask you that what are the drugs that will cause increased uric acid in the body. So one we discussed right now in the list of modifiable risk factors, thiazides and loop diuretics, very important, right? Apart from that, we have certain immunosuppressants such as tacrolimus and cyclosporine. Always do this, okay? So you can't remember each and every means individually. Always make groups, always do this grouping technique to remember any big list in case of medicine, any subject, okay? So one list is of thiazides, means any drug which is related to your kidney. Now there are two immunosuppressant drugs, tacrolimus and cyclosporine. Now there are two drugs related to TB, anti-TB drugs such as ethambutol and pyrazinamide. Now there are drugs which are related to the CNS drugs. So one of them is an anesthetic, one is for Parkinsonism, levodopa, okay, methoxyfluorine and levodopa, and one is left which is a NSAID, that is low dose salicylates. Mind you, now you should break my head and say, excuse me madam, just now Dr. Mad, you commented and said that in case of acute episode of gout we will give NSAIDs, and then you should ask me that aspirin, that is salicylates, it is also an NSAID. So mind you, my dear people, aspirin is contraindicated in gout. Whenever there is acute episode, either we give indomethacin or naproxen or ibuprofen. We never give aspirin because aspirin causes gout. It is never used in the management of gout, of course. So again, this is a little controversial point. So gout is full of controversies, right? Low dose aspirin, that too low dose aspirin. If you ask me, aspirin can come in 2 doses, right? 75 mg aspirin, that is called low dose aspirin, and another is the high dose aspirin, like 325 mg or anything beyond that, that is high dose. So it is specifically this low dose aspirin, 75 mg low dose aspirin, that will cause this gout, okay, that will predispose to gout. Low dose aspirin, just don't say aspirin, say low dose aspirin, 75 mg, okay? Yeah, so this is clear. Now coming to diagnosis. In diagnosis, the best diagnosis is synovial fluid examination. Synovial fluid examination, you can take out, aspirate the synovial fluid from the joint, okay? You can call it osteocentesis, right? Synovial fluid examination. In this, you will get number 1 is a monosodium urate crystals, MSU, that's even a standard short form, right? MSU crystals will be there. These are strongly negative birefringent. They are negatively birefringent, okay? Strongly negative, this you have to remember, negatively birefringent, okay? because when we study, when we study amyloidosis, we study that it shows an apple green birefringence, but in case of gout, the MSU crystals, they are negatively strong, that too strongly negative birefringence. Number two, they are bright yellow in color. I'll show you the image, but still, wow. And they're needle shaped, so needle shaped and bright yellow in color. Okay. So whenever there is an acute attack, the crystals, they may become intracellular, and after the attack, they will again come out into the synovial cavity, into the synovial fluid, and become extracellular. So these are so notorious, so damn notorious. You see, two things are happening. One is that in your joints there is acute episode. During acute episode of gout, these are the joints, and this is your, say, blood. Okay. So both the things will make a poor clinician. Both the things will cause a lot of problem for the clinician to diagnose during an acute episode of gout. Why? Because the first point I told you, the first controversy was that during an acute episode, the serum uric acid levels may be absolutely normal in the range of 4 to 7. Nowhere they will be elevated. This is the first paradox. The second paradox is that you will say that, oh my god, yes, my theory is good, I was always a bright student. You are a resident, you are a bright student, yes. So you will say that, oh my god, don't worry, uric acid, the serum uric acid levels, it is always, very delusional. It is not always clear, because I have studied in my books, and Dr. Matt taught me that it was 4 to 7 also. It can be in the normal range also. So don't worry, I will do aspiration of the synovial fluid, and I will look out for these uric acid crystals, because then that will be a very clear thing, and there can be no discrepancy in that. But hello, sorry my dear student, there will be discrepancy here also. There may be discrepancy that there are all these inflammatory cells, and these inflammatory cells, they will engulf and they will have all the uric acid crystals within them. So if you do the aspiration, and if you only take out the fluid, the synovial fluid, and if much of the cells don't come into your syringe, you will again be in a big confusion. So these are the two paradoxes you have to remember. In case of acute gout, the serum urate levels may be normal, and number two, even the uric acid examination may not show urate crystals, MSU crystals. Then you should ask me that things are becoming too difficult. How will I ever make a diagnosis of acute gout then during acute episode? Don't worry and don't be disheartened. You can do that, because you will see the WBCs. These WBCs, they will be elevated. Okay, so WBCs, they will be elevated, and what is the level? 15 to 20,000 per microliter. So you can go for WBCs. In the plasma also there will be leukocytosis, and even in that synovial fluid there will be increased WBCs in the synovial fluid, because there is a lot of inflammation going on. There will be neutrophils. It will always remember, and that it will be a neutrophil predominant. Okay, out of all the leukocytes in the synovial fluid, there will be neutrophil predominance, and in the blood again you will get the total leukocyte count elevated, and there also there will be specifically neutrophilia. Okay, apart from that, the other the other indicators of inflammation will be the C-reactive protein and ESR. They will also be elevated in the blood. Okay. Now, the hallmark of gout is that tophaceous deposit, or tophi. That is the hallmark of gout, the tophi. Now, what is the tophi? This is the structure of a tophi. In between there is uric. It's just like a granuloma. If you remember granuloma, for example, non-caseating granuloma. In the center, if it is a caseating granuloma, in the center you have this caseous cheese-like material, and then you have all these macrophages. Okay, epithelioid cells, which are modified macrophages, slipper-shaped cells with a vacuolated nucleus, and then you also have these joint cells, and then in the more towards the periphery you have all these mononuclear cells and lymphocytes, and sometimes there may be a fibrotic cap around the whole thing, right? Similarly here, the large aggregates of urate crystals. So whenever you will analyze your tophi, if you do the histology, the studies of a tophi, how does a tophi actually looks like under the microscope? It's just like a granuloma. So sometimes a tophi may be called, in the question they may ask you indirectly that there will be a granuloma formation. That means they're just trying to relate the tophi, which is just like a typical granuloma. In between, rather than a caseous material, there will be all this urate crystals will be there, monosodium urate crystals, needle shaped yellow crystals will be there, and around that you will have all the three types of cells, Okay, you will have these giant cells, you will also have these mononuclear cells, monocytes, and you will also have certain lymphocytes. Okay, so this is granuloma or a tophi, that is the hallmark of gout, tophi formation. Now, and if someone asks you that what are the types of these giant cells, these are foreign body giant cells. These giant cells, they will be FB, foreign body giant cells, foreign body giant cells. Okay. Now, what is the specific diagnosis of gout? The specific diagnosis of gout is increased uric acid in the synovial fluid of the joint. Increased uric acid, which may be also in the form of MSU, monosodium urate crystals. That is a specific diagnosis, because no one after that can ever say, like, no one can deny the fact that the person is having gouty arthritis, because you have showed them the urate crystals in the synovial fluid in their joints. You have demonstrated the urate crystals. Now no one can deny the fact that he or she is suffering from gout. But the problem again comes, I told you that during an acute episode, you do the aspiration, you may miss these uric acid crystals, because they may have all hidden themselves, and they might have all been engulfed into the macrophages. So that is a little problematic. Otherwise, if you can demonstrate anyone the uric acid crystals in the synovial fluid, or even increase uric acid levels in the synovial fluid, whether you can demonstrate then you can demonstrate number one, the crystals, or simply increase uric acid in the synovial fluid. So this will be the most specific diagnosis. Now coming to the complications. In case of kidney, what happens in case of kidney? We get gouty nephropathy, that is called chronic urate nephropathy, because I told you gout has two forms: acute gout, acute episodes that occur, and second is the chronic gouty arthritis. So during chronic conditions, it can cause gouty nephropathy. And second, we discuss again this, there is a predilection to form gouty arthritis, to form the renal stones, also called nephrolithiasis. Now coming to the treatment number one is allopurinol. So hypoxanthine is converted to xanthine and then converted to uric acid. At both these levels, the enzyme is xanthine oxidase. So allopurinol is a xanthine oxidase inhibitor. Now comes a very important question, that what is the management of acute gout? The person is having an acute episode of gout. So how will we manage this acute exacerbation? The person is in acute pain, right? His joints will be tender and he will be in great pain. So how will you do this? And if someone asks you in a viva question that what is the grade of tenderness? What is the grade of tenderness of the joints? So actually there are 4 grades of tenderness of any joint. The grading is grade 1, 2, 3 and 4. Grade 1, does anybody know? The patient feels pain on touching. Number 2, the patient cries on touching. The first is that he just feels the pain on touching, otherwise he's normal. Second, there is more pain. So when you touch the joint, the person is like crying out of pain. In the third stage, the person quickly withdraws the joint upon touching. And the third and the last stage, fourth, is the patient will not allow you to touch the joint. So here we get grade 4 tenderness in case of acute gout. So we can give NSAIDs. I told you endomethacin, never give aspirin. Endomethacin or naproxen can be given. The best drug is endomethacin. Apart from that, you can give colchicine and steroids. And for the maintenance therapy, there are 2 agents we can use. One are those drugs which will decrease the synthesis of uric acid. The number 2, which will increase the excretion of uric acid. These are called uricose-uric agents. So uricose-uric agents, we have 3. One is probenecid, one is benzbromanone, and one is sulfenpyrazine. So usually we use more of probenecid. If you ask me that out of these category of drugs, which drugs is used more in the market, whether it is the uricose-uric drugs such as probenecid, or is it the drugs which increase the synthesis of uric acid such as allopurinol? So which is used more in clinical practice, and practically which drug is more effective and usually prescribed to the patients for a maintenance treatment of gout? It is allopurinol. It's always the better and preferred drug as compared to all these probenecids and benzbromanone and sulfenpyrazine. So yeah, these drugs which are xanthine oxidase inhibitors decrease the synthesis of gout. The classical drug is allopurinol. So allopurinol by far is the most popular drug in the gout. Whenever they ask you the most popular drug for acute, not acute episode, but for a long-term treatment, it is allopurinol is the preferred drug. After allopurinol, you can give second line preference to probenecid. And if the person cannot take allopurinol, we can have febuxostat. Okay, febuxostat we can give. It is a more specific drug, and the newer drug is coming up, and that is called pegloticase. It's a new drug. All the treatment when the patients have failed, it is a refractory gout not responding to allopurinol, febuxostat, then we can give, or the patient somehow is contraindicated to take allopurinol, then you can give pegloticase. Then we can give this drug pegloticase, a new drug again. So any new thing is high yield. Yes. So till now, I hope this was very clear with you. Yes. Let's have a look at the images. So this is gout. As you can see, the joint involvement. The first metatarsophalangeal joint is the most commonly involved. There is inflammation in the joint. Inflammation, all the mediators are there. These will cause lysis of the joint. The articular cartilage will be affected, the synovial membrane will be affected, and finally the joint, means the bones, will also be affected. For that, you need to have a look at the typical joint. If you have forgotten, let's have a review. So whenever there will be a joint involvement and there is arthritis is a very big term. It will have its separate small components. First, there will be synovitis. Oh my god, which color will be conspicuous to you? Synovitis, that means the synovial epithelium, it will be involved first. There will be involvement of the synovitis, and because of these involvement, if the synovial fluid is secreted by the synovial epithelium. So this synovial epithelium, it is having two types of cells, the type 1 synovial cells and type 2 cells, or type A cells, type B cells. So the type B cells, they are responsible for the secretion of this synovial fluid. Type B cells, they will synthesize and secrete the synovial fluid, which is important for the lubrication and easy flexible movement of any joint. So when there will be gouty arthritis, all these synovial membrane will be affected, synovial cells will be damaged and they will die, there will be degradation. So even type 2 synovial cells will decrease, so the amount of synovial fluid will also decrease, and so the person will have a lot of friction and joint pain when he will try to move the joints, because synovial fluid, the lubrication is decreasing. That is the first involvement, means synovial membrane, synovitis. Later on, if you know that any joint, it is having this articular cartilage. This articular cartilage on the opposing respective bone surfaces, there is covering of this articular cartilage. So this will be affected in the second, as the second thing. The first is synovial membrane, synovitis. The second implication is arthritis. That means this cartilage involvement, articular cartilage, will also be affected. There will be a lot of tissue injury, and again that will cause more and more pain when the person will try to move these two bones together, because this articular cartilage also provides level of lubrication and no direct contact between the two bony surfaces, but now there will be more contact, so that will further aggravate the pain, and that is why the reason the person has such as high tenderness, grade 4 tenderness, is because of all these causative factors. So one is synovitis, number 2 is cartilage involvement, chondritis, and then finally over long-term cases even the bones will be involved. These bones will also involve, and there will be osteitis, a long-term osteoarthropathy. Okay, and not only the metatarsophalangeal joint, over the long term other joints will also be involved, such as elbow joint, knee joint, okay, joints of the wrist, etc. will also be involved in long-term cases. Okay, so this is there. And now whenever there will be gout acute episode, there will be in this synovial fluid a lot of migration of the inflammatory cells, mainly neutrophil. Always remember, this inflammation is neutrophil predominant. So neutrophils will come. Apart from that, the macrophages, they will also come, and these will try to engulf the uric acid crystals which are present, and after engulfing the uric acid crystals, there will be a release of so many proteolytic enzymes and inflammatory mediators such as LTB4, prostaglandins, that will cause a lot of tissue destruction. Tissue destruction means synovitis, chondritis, osteitis. Okay, tissue damage. And apart from that, these will be chemotactic in nature. The inflammatory mediators such as LTB4, it will cause more and more recruitment of other inflammatory cells such as macrophages. These macrophages, again, they will try to engulf the uric acid crystals, but in doing so there will be a lot of inflammation, that is called crystal induced inflammation, and that will cause extensive joint and soft tissue injury. Okay, And so when we will do the x-ray, I will show you the x-ray. In the x-ray you will get punched out defects. There will be punched out cystic defects in the bones. And also what will happen, apart from that, that punched out defects will be seen and erosions will be seen. So you can call it as Merkel's sign or G sign. Second thing, what happens in the long-term cases, like those long-term cases who are having these arthritic problems for years, in them there will be remodeling in the bones. There will be osteoclasts are also macrophages in the bones. So these osteoclasts, these will remain activated always, because there is an inflammatory process. The basal inflammation is always there. Osteoclasts, when they are activated for a long time, over months and years, these osteoclasts will start the changes in the bone. They will cause remodeling of the bones, and even there will be breakdown in the bone and compensatory new bone formation, and that new bone formation will also be seen in the x-rays. Okay, now coming to, we have studied everything. Now let's study that whole in one single flow chart, and let's review all the important points we went through just now. So the center place is hyperuricemia. This hyperuricemia can be caused because of two things: overproduction of overproduction of uric acid or decreased excretion. So overproduction can be because of high purine diet, all these non-veg foods, modifiable, non-modifiable risk factors, alcohol intake, certain genetic conditions such as HGPRT deficiency, or PRS overactivity, that will increase uric acid. The second cause for increase in the uric acid in the blood will be under secretion of uric because of certain kidney diseases, diuretics, as we know, loop diuretics, thiazides, lactase, whenever there is acidosis. Okay, whenever there is acidosis, and these conditions, these ones are not important, these are too extensive. For a medicine point of view, you need not know them. They are too much of pathology and deep details. We don't want them right now. So this when uric acid levels is increased in the plasma, when the solubility limit is exceeded, it starts to no more remain soluble, and it starts to crystallize in the form of MSU crystals. And these MSU crystals, okay, supersaturation has been occurred, which pH will favor their formation and crystallization. These are MSU, you can see again, needle shaped crystals, yellow in color, strongly negative bidifferential. The pH is always acidic pH. So this is a positive feedback, that when uric acid is increasing, the uric acid itself is acidic in nature. That means the pH will decrease. So this is the reason that whenever there is increased uric acid in the body, there is increased chances of getting acute episode of gout, because acid will further cause the formation of crystals, or the crystallization will be more in case of acidic pH. So see how uric acid is playing in a double role. By a double role mechanism, it is causing this gouty arthritis. Number one, it is the uric acid only that will form urate crystals, monosodium urate crystals. Number two, this uric acid, as it remains elevated, it causes the acidosis in the body, and that further causes the precipitation of these crystals. Oh my god. So what a good strategy it has used. Very cunning, right? So that was about the pH, acidic pH, and the temperature is always cold temperature. This is one of the reasons why metatarsophyllangeal joint, which is present in the periphery, and there is a lot of heat radiation from this area. So it is the most commonly involved joint. And then obviously joint trauma and debris, all that. So in the acute conditions, there will be the role of interleukin 1b. The main mediator, you can remember here, just to learn the name of this one single mediator, interleukin 1 beta. Interleukin 1 beta, you need to remember. Inflammasome activation, we'll talk of inflammasome. Keep this in mind. A new theory is being promoted, that is inflammasome theory. We'll talk about that in the end for 1 minute. And all that's immune cells, blah blah blah. Okay, so one is the cells which will be released, and number two will be the mediators, and all of these will, as I told you so many times, they will cause joint injury in the form of, number one, synovitis, then chondritis, osteitis, even the soft tissue injury. The periarticular tissue will also be damaged over the time. There will be tophaceous deposits, gouty arthritis, the stophies will be formed, and all this will keep happening. That was acute gout, and resolution also occurs. Why the resolution? It is usually an acute gout is a self-limiting condition. Means even if the patient does not take any drugs for those 7-10 days that we give NSAIDs and steroids, and somehow he can bear that pain, because usually it's unbearable. But if somehow a patient has a very good pain threshold, and if he bears that acute pain for 7 to 10 days, there will be a self-limiting. The episode will go back itself without taking any medication. Why? Because I told you, when there is inflammation, as we know, there are 5 cardinal features. One of them is increased temperature. So increased temperature, that localized area, the temperature increases, and you know, when temperature increases, the solubility of uric acid will increase. So it will be no more in a crystal formation. Slowly that uric acid will start to get again dissolved, means the solubility level will increase with increased temperature. And so within 7 to 10 days, because of extensive inflammation, the temperature, local temperature rises. It is always up, and that is one of the reasons that an acute episode is self-limiting in nature. And in the chronic gout and tophi formation occurs because all the time I told you there is always a basal level of inflammation. Inflammation is never off, the switch is always on. The intensity differs. In an acute episode, that inflammation is at the highest speed, say gear 5. But even during chronic gout, you're still driving and maybe in the first gear or the second gear, but still that inflammation is on. It's on, maybe with a lesser intensity, but it's still on always in case of chronic conditions. So macrophages are always activated. As we discussed, this granuloma formation, that tophi, it is just like a granuloma. In the center there is uric acid crystals, which acts like a foreign body, and it causes a lot of recruitment and chemotaxis of all the different types of cells, giant cells, macrophages and lymphocytes, and it occurs, okay, granuloma tophi formation. MMP production, matrix metalloproteinases, that further causes accelerated joint injury. That is the reason in the x-ray we get all these erosions, punched out defects, and osteoclasts, which cause erratic new bone formation. That is written again, osteoclast activation. So each and every aspect we discuss meticulously. Yes, this is only the inflammation part they're depicting. That was the whole story. That is inflammation. Hyperuricemia, precipitation of uric acid crystals. These uric acid crystals, they will cause activation of the complement system. Complement system will then give knock, and they will stimulate the neutrophils. The neutrophils will come, they will try to phagocytize these crystals within them. But during this process there will be a lysis of neutrophils and release of all the enzymes, proteolytic enzymes, lysozymes and all. And during the process of phagocytosis, neutrophils, they will also release all these inflammatory mediators. There are always two aspects of inflammation: inflammatory cells, inflammatory mediators. Inflammatory cells will be both neutrophils and macrophages, but it is neutrophil predominant. And then inflammatory mediators, as we discussed, LTB4, prostaglandins, free radicals, these will be responsible for the joint injury and inflammation. The second cells which are coming after neutrophils, the second preference is phagocytosis by the monocytes, macrophages. They will also release so many interleukins. You don't have to remember all this nonsense, it's not important over here. The inflammatory mediators are not important in case of gout, okay. And again, the injury at multiple levels, synovium, synovitis, cartilage, and even bone later on will be destructed because of all these enzymes such as proteases, which will break down the proteins. Our body is made up of proteins, the building blocks of proteases, and even matrix metalloproteinases, MMP. Again, that will add to the tissue injury. So this is that characteristic tophaceous deposit. What is tophaceous deposit? And when we will try to see this histology, it will be nothing but so much uric acid, crystals of uric acid, and surrounded by different types of inflammatory cells of the body. Okay, and this can occur anywhere in the joints or around the joints. Okay, tophaceous deposit. Soft tissues also, cartilage is not spared. This is the typical defects you see here. This is erosion, the punched out defects. Why? The bone has been completely eaten up by your macrophages over the long time. The bone has been eaten up, so this hollow type thing you see because of macrophages, osteoclast activation. They are releasing proteases, matrix metalloproteinases, lysosomal enzymes, and this is also osteoclasts, which will also cause erratic new bone formation. So this is simple, and this is called Merkel's sign. This is an uncommon thing, but again it may be important for the PG point of view, but for theory it's not at all important. Merkel sign or G sign, all these punched out defects which are seen. Okay, so that was X-ray. Oh wow, so these are the urate crystals. As you can see, needle shaped crystals, yellow in color, and negative for birefringent, strongly negative birefringent. Yes, okay. So these are the same things that I took out, means this is showing the microcrystals. This is the same theory I told you, that why after giving drugs all of a sudden there is a chance of precipitation of another acute episode, because these drugs, they will try to mobilize the uric acid from the crystals, and this uric acid which is coming out of the crystals, a microcrystal liberation of uric acid from the tophi or the microtophi, is possible that these crystals may not only be pro-inflammatory but may also serve as a nuclei for further crystal formation, because whenever there is a crystal formation they need some triggering initiating factor and nuclei, and these microcrystals which are dislodging and immobilizing, okay, from the main tophaceous deposit. After giving a drug such as allopurinol, they will again accumulate anywhere else and act as a nidus for the new crystal and tophi formation. Temperature, we discussed that it has shown studies performed in aqueous blah 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 suggests that a reduction of even 2 degree from 37 to 35 degrees Celsius is sufficient to lower the solubility point of urate from 6.8 to 6 milligram per deciliter. And this again the whole logic that why metatarsalophalangeal joint was involved. Then again, why gout is self-limiting, because over the time inflammation, there is increase in temperature, calor, right, and that cause the joint, and also other factors, obviously the other cells also come, macrophages and all, there is a lot of host immunity also, but one of the factors is temperature also. Then the pH, acidic environment, always remember acidic pH, and again uric acid is acidic, and alcohol also causes acidosis in the body, okay, so because of these factors, acidosis, it precipitates acidosis precipitates the crystallization. This we discussed, done, and again done. Now I think everything has been covered, but let's give a quick view to Harrison's. And one more thing, inflammasome. What is inflammasome? So they will say that gouty arthritis is based on the inflammasome model. So just a little bit you need to know. Inflammasome is nothing. It's a multi-protein oligomer. Oligomer means 2 to 10 units it will have of different types of proteins, multi-protein. Whenever this is a part of the innate immunity, it is a part of innate immunity. Inflammasome, just remember, it's a type of a protein, a little complicated protein. And this will be triggered whenever this crystal induced inflammation, it will cause the excitation of this inflammasome, which is sort of a protein. This inflammasome, whenever gets activated, causes increased levels of interleukin 1 beta in the body. This interleukin 1 beta, as I discussed, this is the only inflammatory mediator. You can remember the most important inflammatory mediator of gout is interleukin 1 beta. So the secretion of these cytokines result in a pro-inflammatory cell death. And in case of dysregulation of inflammasome and blah blah blah, it is expressed in myeloid cells, and it is a component of innate immune system. That's inflammasome done. It is a part of innate immunity. It gets activated by these crystals, uric acid crystals, and it causes increased expression and secretion of interleukin 1 beta. Interleukin 1 beta will cause all the cascade of inflammation, tissue damage, and gouty arthritis. So this is here. Synovial. So as we discussed, the mainstay is synovial fluid analysis. Okay, that is the best diagnosis you can do. Synovial fluid analysis. Yes, synovial. Yeah, synovial fluid analysis to distinguish the type of crystals also. Okay, sometimes there are means in this crystal mediated arthritis, it can be gouty arthritis, it can be calcium apatite crystals, it can even be calcium oxalate crystals. But for us important is only MSU crystals, that is gout. And that is what we discussed. Polarized light microscopy, strongly negatively birefringent. Okay. And synovial fluid analysis will also help us to know the inflammatory mediators and means the inflammatory cells. Yes, because in case of gout it is neutrophil predominant. So synovial fluid will not only show you the crystals per se, the uric acid crystals, but obviously it will also show you the inflammatory cells, which is neutrophil predominant. Then gout, as we discussed, middle age, blah blah blah, all this we discussed. Yes, and various manifestations also we discussed, synovitis and chondritis, all that. Acute arthritis is there, again the same thing, metatarsal joint, later on ankles and knees, all that. Sometimes you may get these Heberton's or Bouchard's nodes, but these are more important for rheumatoid arthritis. These are the nodes which we get in rheumatoid arthritis, and the PIP and DIP in the interphalangeal joints. These nodes are not important for gouty arthritis, so don't confuse yourself, because these are very important characteristic for rheumatoid arthritis. So in gout you may get them sometimes, so it's not important to remember at all. Episodes may begin at night. Again, at night if the episodes are beginning, that means colder temperature and relatively decreased perfusion in the periphery. Okay, and again it is self-limiting. After 3 to 10 days the person will be normal, self-limiting after 3 to 10 days. But if chronically it will occur, then it will cause chronic synovitis, chondritis, osteitis, and also the periarticular tophaceous deposits, that is like a granuloma formation. Then again there is a strong family history, and also the kidney being involved, decreased clearance of uric acid from the kidney. In lab diagnosis, again we discussed the best is the needle aspiration. Okay, of the joint or of the joint or toffee, we can do the needle aspiration. And there are very differential diagnoses such as septic arthritis, other crystalline associated arthropathies, and psoriatic arthritis, which may present with similar features. But in case of gout, during acute attacks, we are looking for these needle-shaped MSU crystals that are typically may be present intracellularly, they will hide, or they will be extracellularly. Okay. And again, it is written that they are negative for birefringence, so the same point is highlighted again. Okay, negative birefringence. Then I also told you that the synovial filled leukocyte will also be elevated. We discussed this. And it will be neutrophil predominant, so large amounts of crystals will be there, and also the neutrophils will be there. Then you can even see the uric acid levels, but for that it is better to see a 24-hour urine sample to see the uric acid. Uric acid can be done by having 24-hour study, okay, to assess the risk of stones in elucidating, overproduction or under secretion of uric acid, and deciding whether it may be appropriate to use a uricose-uric therapy. So a 24-hour urine must be used. And the level is 800 milligram. If any person is excreting more than 800 milligram of uric acid per 24 hours, then you will say that there is overproduction. Okay, apart from that, if it is less than 800 milligram of uric acid per day, then it is normal. So the cutoff is 800 milligram. Again, radiologic features in the x-ray we discussed, those punched out cystic defects we discussed, and sclerotic margins, that means erosions. All this we discussed. You can also go for ultrasound, CT or MRI. Acute gouty arthritis, we discussed all that. You have to manage it with NSAIDs. You can even use ice packs. Ice pack applications can be done, and usually NSAIDs are the drug of choice. In that too, it is indomethacin. You can give these NSAIDs, right? And resolution will occur in 5 to 8 days. The most effective and with a short half-life is indomethacin, or you can use naproxen or ibuprofen. We discuss all this. Apart from that, you may use diclofenac. And for glucocorticoids, you can give intramuscular or oral. You can use prednisone. Okay. You can use systemic steroids if the person is having too many manifestations, like many joints are involved. But if it is a single joint or few joints are involved, then you can just give an intra-articular steroid injection of triamcinolone. Intra-articular steroid injection may be used. Then again, I told you this, we discussed that in one line Harrison has used this word, the essential role of inflammasome activation interleukin 1 beta. So for that I also explained you the entire theory of inflammasome that is required to be known. So since interleukin 1 beta is the main inflammatory agent nowadays, there is a lot of investigations going to see the efficiency of anakinra, which is interleukin 1 inhibitor, for the management of chronic gout. Okay, then again, this is hypouricemic therapy. The best is always allopurinol. So urate lowering therapy should be initiated in any patients after he has developed a tophi, that is one, or if he is in a state of chronic gouty arthritis. So these are the two criteria to start with a urate lowering therapy in a patient. Number one, if you are seeing even a single tophi anywhere, or if you are having chronic gouty arthritis. Chronic gouty arthritis means chronically the serum uric levels will be elevated. So these are the two criteria to start the therapy. And then all the drugs are given, we discussed already. Probenecid and benzbromadrone, sulfenpyrazone, these are uric agent drugs. So they are saying that probenecid is not used if the patient is having a renal failure. If the person is having renal failure, then you should prefer to give benzbromadrone as compared to probenecid. Okay. And then there are some other drugs which are having a uricose-uric property. For example, this may be important for pharma: losartan and fenofibrates and amlodipine. losartan, fenofibrate, and amlodipine. Losartan, ARB, it is an ARB, losartan, fenofibrate, okay, hypolipidemic agent, and amlodipine, calcium channel blocker. So all are different groups of drugs. Like losartan, amlodipine, they are used for usually hypertension management, and fenofibrate, these are also having uric property. But the preferred drug is always, allopurinol. They have given allopurinol doses and all, we need not remember. Toxicity of allopurinol has been recognized in certain patients. The most serious side effects are these hypersensitivity reactions such as toxic epidermal necrolysis and bone marrow suppression. So for that, as I told you, the more specific xanthine oxidase inhibitor is febuxostat. It is a more specific xanthine oxidase inhibitor. So with that, we come to the end of gout. And yes, thanks a lot for watching. Please do like, subscribe, share, and comment.